snoring करते हैं and there's sleepless of night. Firstly, I'd like to welcome our dynamic President IMA Maharashtra State, Dr. Suhas Pingle sir. Is busy somewhere, but he'll join. So also I'd like to welcome our very active and always in action, our beloved secretary, Dr. Mangesh Pate sir. So also I think Dr. Ravindra Kute sir, one of again a dynamic leader who is also on the move of all over Maharashtra and always boosting and initiating lot of webinars and also having many of the branches of CGP. Welcome our President-elect, Dr. Ravindra Kute sir. So also I'd like to welcome Dr. Ramkrishna Londe sir, our past president. He will also join. Next, I would like to invite and welcome Dr. Raju Agarwal. He is also dynamic leader and a treasurer of IMA Maharashtra State. Maybe he's busy somewhere. He'll join recently. Next, our CGP director, Dr. Pradeep Kumar Sangle, who has planned this CME, one of, I would say, very important and really day-to-day activity CME of importance of sleep apnea. Next, I'd like to welcome our Joint Secretary, Dr. Jagdish Ramchandani, Dr. Bhavika Chandani, also inviting and welcoming President of IMA Kalyan, Dr. Prashant Patil. Possibly is also busy, will join. Dr. Surekha Litkar ma'am, Honorary Secretary of IMA Kalyan, she has joined. Welcome, madam. Dr. Himanshu Thakkar, Treasurer of IMA Kalyan. Welcome you, sir. Dr. Rajan Mane is also a dynamic personality, Assistant Secretary of Kalyan branch. Now, I'll like to request our active director, Dr. Pradeep Kumar Sangle, to take the further charge of this important webinar of sleep apnea. Dr. Sangle, sir, please take the charge and do the proceedings of today's webinar. Thanks all of you to join. I'll welcome all of the delegates who has taken trouble because this is 9:30 p.m. and I hope a practice in between of the busy schedule, they have joined this webinar. So welcome all the faculties. So also all of the delegates to join this very important webinar. Thanks a lot. Sangle sir, please take over. Thank you.
Thank you very much, Dr. Rajan Sancheti. Thank you very much. I would like now to invite Dr. Surekha Itkar madam to welcome on behalf of CGP sub-faculty IMA Kalyan and IMA Kalyan. Surekha Itkar madam.
Good evening to all the respected dignitaries, speakers and delegates. On behalf of IMA Kalyan, I, Dr. Surekha Itkar, Secretary IMA Kalyan, heartily welcome you all. It gives me immense pleasure to welcome today's guest, respected Dr. Suhas Pingle sir, President IMAMS, Dr. Mangesh Pate sir, Honorary Secretary IMAMS, Dr. Rajiv Agarwal, Dr. Ramkrishna Londe, Dr. Ravindra Kute, President-elect, Dr. Pradeep Kumar Sangle sir, Director of Studies of Faculty of CGP, Dr. Rajan Sancheti, Dr. Bhavika Chandani, Dr. Ram Chandani, Dr. Prashant Patil, Dr. Isha Pansare, Dr. Himanshu Thakkar, and Dr. Rajan Mane. I welcome today's speaker, Dr. Pushkar Shikarkhane, who is a senior physician at Sushrusha Hospital, Wadia, Reheja, and Somaya Hospital, Mumbai, and all the delegates. I welcome you all for today's meeting, hosted by sub-faculty of CGP IMA Kalyan in association with IMA Kalyan, educative webinar on importance of sleep apnea, a physician's perspective. Now I request Dr. Pradeep Kumar Sangle sir to take over the proceedings further. Thank you, sir.
Thank you, Surekha madam. Thank you very much. Snoring is a very common amongst population, and some of them are obstructive sleep apnea, which can cause ill effects on the health, requiring further evaluation. Obstructive sleep apnea is most overlooked, but still very important subject. Hence, it is the topic for the day. And we are fortunate enough that we have got Dr. Pushkar Shikarkhane sir here to guide us on the subject. Welcome, sir. Welcome very much. Now, I would like to request our IMA Honorary Secretary IMA MS, Dr. Mangesh Pate sir. Pate sir is there? I think he will be joining later on. Ravindra Kute sir is there? President-elect.
I think sir has joined. Kute sir has joined.
Kute sir. Ravindra Kute sir. Today, our president is Dr. Suhas Pingle sir is out of station. Is unable to join from there. I just called him, and Pate sir is also busy somewhere. Kute sir has joined. Kute sir. So I would like to call Dr. Rutika Vivek Bhosle, madam, who is young dynamic chest physician from IMA Kalyan, to introduce today's speaker.
Thank you, sir. Thank you for the opportunity. It gives me immense pleasure to introduce Dr. Pushkar Shikarkhane, sir, who's an institution in himself. Sir has completed his UG and PG from Sage GS Medical KM College and KM Hospital in the year 1991 and 1996 respectively. Sir has also got additional qualification and certificate course in practice medicine, practice marketing organized by CCPL Software in 2004, a diploma in effective public speaking awarded by Indo-American Society in 1987. Sir is also consulting physician since 1997 with special interest in health consultancy, sleep medicine and metabolic syndrome, infectious diseases and obstetric medicine. Sir is presently attached to Shushrushra Hospital Dadar, Noroji Vadia Maternity Hospital Parel, SL Raheja Hospital Mahim and KJ Somaya Hospital in Sion. Sir has been appointed as visiting lecturer in College of Physicians and Surgeons of Bombay Parel, Co-Chairperson Scientific Committee of Indian Medical Association Annual Conference 2003, Member of Quiz Committee API Con 2003, Member of Scientific Committee of API Con 2002 Chennai, Associate Editor of Medicine Update 2002, Member of Public Health Education Cell of Maharashtra University of Health Sciences Nashik. Sir is actively participated in activities and speeches for patient education programs in diabetes, art and science of living healthy life, control of infections at community level, how to become fearless, how to achieve total health. Sir has also participated in All India Radio, Asmita Vahini and Arogya's Dhana Sampada, program on diabetes mellitus, importance of yearly health checkup in typhoid malaria. Also participated in television interviews on topics like heart attack, hypertension, importance of family doctor, swine flu, dengue fever, etc. To add to his resume, Sir is also a very good singer. Over to you, sir.
Sir, you are mute.
Yeah, so today is a great day, I would say, in my life. It is an evening which is, I'm sure, going to be remembered by me and by all the friends like you who have joined today's webinar, because this particular topic of sleep apnea and the related effects on the human health has become very close to me and into my practice as my practice has developed. Like I started my medical education in year 1987 at St. J.S. Medical College, and actually started actively practicing as a consulting physician in 1997. And now almost 22 years of active practice has passed, and day by day, as we keep learning and we keep adding our case experiences, and we start practicing that on our new patient that they come, I've really felt and realized that the importance of sleep is extremely significant, and it's the most ignored part in our medical, even education, I would say, and also in our practice. the society per se has been going through a huge transition. Like last maybe 50 to 100 years has seen a tremendous transition in the society, mainly because of the scientific revolution that we have all experienced. And light, the artificial light has become such a common thing to all of us. And because of that, we have started using all the 24 hours of the day to our disposal. Everybody is so greedy to live the life to the fullest that we want to enjoy every bit of life. No? Like nobody wants to waste even 1 minute or 1 second of that. And in that process, to enjoy life, we have easily assumed a fact that sleep is probably a wastage of time. जैसे हमारे कोई लीडर्स भी कह चुके हैं कि आराम हराम है. So not taking relaxing or rather resting or even sleeping has been considered as a kind of a sin to some extent. That if you can utilize that time and make the best of it, it is always considered the most ideal thing to happen. But at the same time, if we introspect and see, the human life actually is dependent predominantly on the sleep, because we all spend almost 1/3 of our life sleeping. So if nature has given us this particular need, or it is a basic, one of the basic necessities of life, it has to be fulfilled. And if you are not fulfilling that basic necessity of life, there is going to be some effect or some damage of that happening on the health. Like how we need food, water, shelter, clothing as important basic needs, sleep is also an equally important need, and this has been identified by one of the greatest psychologists and scientists, Maslow. In Maslow's triangle, if we see, the basic needs includes sleep in that. So this cannot be easily done away with, and we cannot go away from sleep. So sleeping is important, and anything that affects sleep, or anything that damages sleep, or anything that fragments sleep, or anything that does not give us a very satisfactory sleep or a relaxing sleep is bound to affect our health. And one of the most important things that causes fragmentation of sleep is sleep apnea, in which your sleep is actually getting obstructed because of abnormal breathing. Breath is one of the most important things of life, because unless we breathe in oxygen, unless we breathe in good pure air, whatever that we eat cannot be further utilized as a fuel. So oxygen is a most important thing to our cells, and that is what actually generates energy within our body. And because of that energy, we all can do various actions and activities that we do throughout our life. So if this oxygen is obstructed for some reason, our body is going to undergo stress. So I first and foremost thank and congratulate the IMA Kalyan for identifying this as an important topic and inviting me to speak on this topic. The most important and the instrumental person in organizing this event today is Dr. Pradeep Kumar Sangle. So I really thank him from bottom of my heart that he has really followed up, persuaded me, and he has been in touch with me and repeatedly asked me to go ahead with this activity. We also wish to do a physical CME at some point on this topic, where he wishes me to call to Kalyan and we can have a actual face-to-face CME also. But webinar is an excellent idea, because by which we can reach out to many people wide and far. And especially this COVID pandemic has taught us to take this spreading of scientific knowledge to this level with the use of online internet activity. So this webinar has been a great idea. And the entire team of IMA Kalyan, I really thank them. Also the IMA Maharashtra, the CGP cell. So all the names who have been taken, and the way the program has started with Dr. Sancheti and all the other speakers, the way they were spoken. We are lucky to have a pulmonologist introducing me, Dr. Rutika. She has obviously looks from her the way she spoke, a very dynamic pulmonologist, and I'm sure she must be also interested a lot in sleep apnea. So it's a very nice august gathering that we have today. And this gives me a real pleasure to start the today's discussion. Let's have a good interactive discussion. You can keep sharing your even questions on the in the chat box. And I request Ajit and Vikas who are from ResMed. Without ResMed, this today's seminar would not have been possible. ResMed is a pioneering company in the PAP machine, that is the positive airway pressure machines, which is the mainstay of treatment for sleep apnea. So without a good support from their side, this event would not have been possible. So if both of them can keep a track of the questions, and as I complete my talk, maybe we can have the interaction also, whereby they can read out the questions to me and I will try to answer. I think we have what 45 minutes to half an hour or to about an hour for the today's talk that has been permitted to me. I'll try to stick to my time, and we'll have a nice fruitful interaction. So we can start with the screen share. Already Dr. Rutika has introduced me. Let's go to the full screen. Yeah, so importance of sleep apnea, a physician's perspective. I chose this topic is because I am a physician. I'm basically MD medicine. So that why I'm trying to differentiate is that we have predominantly the chest physicians, the doctors who have specialized in chest medicine. They have been mainly dealing with sleep apnea for last many years, because obviously it is a problem related to breathing. What the problem that I have observed over the last few years is that the chest physicians will mainly see patients who are referred to them from respiratory problem. So unless the sleep apnea is suspected in the community, and that is mainly done by all the other branches, as you will see that the variety of symptoms and diseases this illness can cause, it causes more symptoms and diseases which are outside the chest as a part of the body, I would say, right from brain to the kidney to liver and to heart and skin and everywhere. So unless all the other specialty branches start understanding the possibility of sleep apnea as a root cause of the illness that they are dealing with, the patients will never reach the chest physician for getting a sleep study done. The very obvious sleep apneas which are seen in obese people and people who are snoring very loudly, they may be sent to the chest physicians for further investigation. But there is a big sleep apnea population which is beyond these type of typical and classical sleep apneas that we have been seeing. And these can be only identified by a good family physician or a good consulting physician, or even the specialist from other branches like a cardiologist who is seeing a patient of coronary artery disease, or a neurologist who is seeing a patient of stroke. So unless they become aware of this, unless they start looking for it, it's not possible to diagnose sleep apnea, and then the treatment becomes the next part of it. So let's see what is sleep apnea. I think small introduction has been given. So it is basically the broad term of sleep apnea is called sleep disordered breathing. It is the disorder in the breathing which is associated with sleep. Now, there are various points which are there in this. The primary is snoring, because not all those who snore have sleep apnea. So some people may just have that noise which is produced, but they may not actually choke. So, but the commoner forms of the cases where we see is something called an upper airway resistance syndrome, which is a milder form of obstructive sleep apnea. These are the cases where there is limitation to the flow of air as the air enters our nose and then passes through the throat and then goes into the larynx and then into the lungs. The passage which starts from the nose, which goes to the throat, that area is the one where the obstruction is occurring. So if the obstruction or the flow of or the limitation to the flow is occurring at that level, which is not very severe, as we will see the criteria, it falls into the category called a UARS. And why this difference between UARS and OSA is that these patients can be phenotypically different. So they may have different characteristics. Just to give you an example, these UARS patients are generally not very obese patients. They are the slim sleep apneics. these are the patients who may have more of difficulty falling asleep. So they are not the one who are hypersomnic, they may be insomnic. Or rather, these are the patients who may have symptoms of anxiety more, or they may have in fact hypotension than hypertension. So this is a mix of illnesses which are seen, and that's why we need to get into more and more details of sleep apnea and start and become more qualified to identify them. The other commoner part of sleep disorder breathing is OSA, and there's other long list which we are not going to focus today, and not to complicate the matter too much, because as I understand, we are all in the stage of infancy as far as we are learning sleep apnea. So let us go small steps at a time. So central sleep apnea, Kine-Stokes respiration, overlap syndrome, nocturnal hypoventilation, complex sleep apnea is something which I am not going to deal with today. We will focus predominantly on sleep apnea. So what is this obstructive sleep apnea? Obstructive sleep apnea occurs when there are repeated episodes of complex or partial blockage of upper airway during sleep. And this is measured as AHI, that is apnea hypopnea index, in the sleep study. As you will see in this diagram, this person on the left side has a patent airway, and there the air which has entered the nose has easily passed into the lung. But whereas the person on the other right side is showing obstructive apnea, where the tongue has actually fallen back and it is touching the posterior wall of the pharynx, and that is where the air which is coming in is getting obstructed. The soft palate is also going and touching back, and it is returning back. So there is obstruction. As I had told you a little about URS, it is something which is not meeting the criteria of OSA, but it also causes sleep fragmentation. It also causes brief awakening from the sleep multiple times, and it is measured as flow limitation or respiratory effort related arousal on the sleep study. Now, what happens because of this upper airway collapse during sleep? So as you will see that a person now starts the sleeping, the sleep starts. As the sleep starts, as you know that when we relax, the muscles also relax. So as the person is lying supine or flat in the bed, the tongue starts falling backward. And this does not happen to every human being, but it happens with the people who are suffering from sleep apnea, where they have some anatomical structural problem by which their tongue is either larger in size, or their jaw is small, which is slightly backward place, that we call as retrognathia, or they have some other narrowed airways. And this, as you would be amazed to know, that animals have much less sleep apnea compared to human beings. And you would obviously ask me a question that why this happens. So it is basically the price that the human race is paying for the voice quality that they have got. We as human beings can produce different types of sounds and voices so that our language function has developed. And because of this ability, our pharynxes are much flexible. Now, the flexibility gives the chances of collapse also. Because the pharynxes are flexible, they tend to collapse also easily. And then the unfortunate thing which has also happened along with the scientific revolution, as I was saying, the urbanization, you may call it, as the easy availability of food has led to obesity. Now, obesity and lack of exercise, both these factors put together has, or rather excess food intake and a lack of exercise has led to obesity. And that also increases the neck size. It also increases the fat inside the neck, and all these things further compromises the airway. So now this compromised airway can get obstructed in the sleep multiple times. Now, as the airway closes, what happens is that the air does not go into the lungs. It's very simple thing. There's no rocket science as far as sleep apnea is concerned. It's a very simple disease. There are no complicated enzymatic reactions or no complicated hormonal thing happening. It's a very simple mechanical illness, whereby because of the obstruction, the air is not entering the lung. As the air is not entering the lung, the oxygenation of the blood is not going to happen. Now, when there is no proper oxygenation happening, it can cause hypoxemia. Now, as you know that we are even worried when in a COVID patient, if the oxygen level drops below 95 oxygen saturation, we get worried and we even ask the patient to get hospitalized. But you will be obviously surprised to know, or many of you already know about it, that in sleep study, when we read the reports, the patients who are suffering from sleep apnea, the oxygen level can go as low as 70, 65, or even many are in the range of even below 90. So that kind of intermittent hypoxia keeps happening throughout the night. Obviously, when the breathing is not happening properly, there is retention of carbon dioxide also. Now, this hypoxemia plus hypercapnia is sensed by the brain, because our body needs this basic need of oxygen supply and clearance of oxygen, carbon dioxide. If that is not happening, the brain alerts the body, and body is awakened. So there is arousal. So the sleep is broken at that time, and the person is aroused from the sleep, so that the muscle tone inside the pharyngeal muscle as well as the tongue improves, and the obstruction is temporarily relieved, and the air enters into the lung. And this keeps on happening throughout the night. So the upper airway opens, but the upper airway open remains for a short period of time. The person again slips into the stage of sleep, and that stage of sleep again causes closure of airway, and again hypoxemia, and this vicious cycle continues. Now, what is the effect of hypoxemia and hypercapnia? As it is a stressful situation to the body, there is sympathetic nervous system oversurge that happens. Anything that causes threat to our life puts you into a stage of fight and flight mechanism. And fight and flight mechanism, there is accompaniment of all the release of stress hormones. So it will be adrenaline, noradrenaline, cortisol. All these stress hormones are released, which will increase the blood pressure, which increase the heart rate, which increase the blood sugar, and all these things keep on happening throughout the night. And the sleep obviously is getting fragmented, which is not allowing our brain to relax. The sleep is necessary, or even our body to relax. The sleep is primarily required for us for the good healing of all the wear and tear that happens throughout the day. So this recovery or the healing process is going to happen through the sleep. And if that sleep is fragmented, we are not going to go through the necessary stages of sleep, and that will cause damage to the body. The brain will also not go through the proper relaxation, and the body also will not go through relaxation. So this is the primary pathophysiology of sleep apnea, and the effects of that on the body, what they happen, we will see that now. This slide I purposely, these few slides which are going to come now, I purposely put them at the beginning, because this is how a patient is going to present to us. Unless we look for these signs and symptoms and these diseases, unless we start taking these diseases seriously, unless we start not considering sleep apnea as a possible diagnosis for this diseases, or a possible root cause of diseases, we are not going to pick up cases of sleep apnea. Now, when I have started picking up cases of sleep apnea, I purposely got a little statistical data collection done, and I found that almost 80% of patients whom I am asking to get sleep study, they are coming out very positive. So that is the level of suspicion that we are developing, and then the cases you start picking up, and they may have come to me for variety of these symptoms that I am going to describe to you. So snoring, in the initial introduction also, Dr. Sancheti and Dr. Sangle, they mentioned about snoring as a major symptom, and this, as you know, that is the cardinal symptom of sleep apnea, where the person makes a noise, and it can be of variety of severity. It can be mild to severe. It can be as severe that it can be a reason for a marital discord. Also, the bed partners can be very unhappy with this kind of thing. Now, this has even led to divorces also in some families. But many families have suffered from many persons have suffered through the snoring of the bed partner. It has been there for last so many years, and the tradition has been not to speak against the bed partners, so people have actually accepted and suffered. And I have seen this happening in my consulting room when I have thought of a person's probably suffering from sleep apnea, and I look at the person and ask this question, that how is your sleep? This is the common way I start my interaction on how I ask the sleep history. And as they start discussing or describing the sleep, I also give a leading question, that do you snore? Now, when I ask this question to say a couple who is sitting in front of me and I am actually facing the husband and ask him, do you snore? The answer comes from the side. The wife immediately says, yes, अरे ये तो बहुत बड़े-बड़े जोर से खर्राटे लेते हैं. And this, for my own sake, I have made up my mind that in the latency period with which the answer comes, like if you ask the question and the answer is given with a very short gap, then you understand this person has a very severe disease. Because till now, no doctor has asked this question to the gentleman कि आप snoring करते हो क्या? And now this lady feels that this is the only doctor. ये कोई तो मसीहा लग रहा है कि इसने ये सवाल आज मेरे husband को पूछा है. Now I have got the chance to describe how my husband snores. So this is how it's like a indirect way of finding out how severe the sleep apnea is. So jokes apart, but it's important to inquire about snoring. The second symptom is shortened sleep latency. There are people who are described by themselves or their family members. They say that इनको तो नींद का वरदान है. हे कुठेही बसले की झोपतात. त्यांना हवं तेव्हा ते झोपतात. टीव्ही बघताना पण झोपतात. ह्यांना कसला झोपेचा आजार असणार? This is how people argue with you. Like when you say that this illness is possibly related to sleep, they say इनको तो कोई प्रॉब्लेम ही नाही, तर मनाला येईल तेव्हा कुठेही झोपू शकतात. So this is, आणि पलंगावर तर ते पडले की क्षणात ते झोपतात और इमीडिएटली कुछ क्षणों में वो खराटे लेना भी शुरू करते हैं. तो ये नींद भी इमीडिएटली आती है और खराटे भी तुरंत शुरू हो जाते हैं. Now that is considered for all these years that it is a good thing, but actually it is an indication of sleep apnea, because one is not supposed to get into sleep immediately. There is always a gap of about 10-15 minutes before you get into the stages of sleep. So initial stage is the stage of wakefulness when you are going through. Then if that stage is shortened, it actually indicates that there is sleep deprivation and the person is quickly falling asleep. So the shortened sleep latency is again an indication of sleep apnea. These persons can sweat at night. Now, getting up for urination at night is also considered by many people as a very natural thing. That हम तो 2-3 बार तो पेशाब के लिए उठते ही है रात में. मतलब this has been accepted as a normal thing by people, but it is an indication of sleep fragmentation. And many a time the tendency to pass urine is just because you are awakened from sleep. And then people tend to even drink water after that because the throat has become dry. So further urination happens after 1 or 2 hours. So some people even get up at night for 5-6 times to pass urine. So this kind of sleep fragmentation, and this is a serious thing. So we need to inquire about nocturnal urination. Some people tend to cough at night. There is excessive salivation. And the very classical symptom that is an indication of sleep apnea is a partner witness stoppage of breathing. So there are some persons ते मोठ्या मोठ्याने घोरत असतात आणि घोरता घोरता मध्येच त्यांचा आवाज थांबतो. उनकी स्नोरिंग की आवाज जो है वो बीच में रुक जाती है और वो एकदम से थोड़े से जग जाते हैं और बाद में उनकी आवाज रुकी रहती है. देन कुछ समय के बाद फिर से वो खराटे लेना चालू करते हैं. So this is again a very classical symptom of sleep apnea where it is a witnessed apnea. As I told earlier that people with UARS who are not having real apneas but they have flow limitation, they are the one who may find difficult to fall asleep. So they are insomniac, and this more of sleep onset insomnia commonly seen in women. So in women, the presentation of sleep apnea can be different from men. So please try to also remember that. And there are some persons who, especially who are getting sleep apneas more in the REM sleep, they tend to have early awakening. So they tend to get up early in the morning because that's the time when the REM sleep, that is rapid eye movement sleep, is happening. And that is the time the muscles are going into further relaxation. That is a state of hypotonia, and that's the time when the airway further collapses. So these are variety of symptoms with which people will come to us. Now the effect of this nighttime abnormal sleep is that there is excessive daytime sleepiness. So one does not get up fresh in the morning. One still wants to sleep more for 1 hour, 2 or more. This can lead to even early morning headaches. So because of this hypercapnia which has occurred at the night time, the carbon dioxide accumulation, people get early morning headaches which are commonly seen. Fatigue throughout the day. उनको थका ही लगता है पूरे दिन भर. Some people describe that fatigue as dizziness. The head is always spinning. So variety of people who come to us for the, they describe that mujhe chakkar aati hai, chakkar aati hai. Many of the chakkar patients may not have actually anything to do with the vestibular problem. The easy, we keep writing beta histine and cynarazine left, right, and center for all the chakkars, but then we need to keep in mind that this can be related to even sleep apnea and poor sleep quality. And work performance also goes down. So many problems. Even in children, there is poor concentration and all these issues, as I'll see further. The common thing that happens because of sleep apnea is metabolic syndrome, because the stress hormones can lead to elevated BP, high sugar, and excess cortisol will cause central obesity. So people who come up with a fat around the waist, this is classical of central obesity, is also because of metabolic syndrome, and that can be because of sleep apnea. Hyperlipidemia, again, effect of excessive stress hormones. Obesity is further increased by sleep apnea. So it is like a vicious cycle. People become more obese. Because of more obesity, it causes more sleep apnea. More sleep apnea causes more obesity, and it's a vicious cycle. So because there is disturbed hunger hormone balance, the leptin and ghrelin hormones which are there in the body, they make you feel hungry even if you don't need it. People who are already having excess fat in the body still will keep on getting severe hunger pangs, and they will keep on eating and munching when it is not required. Hypertension. Now, let me bring your attention to this topic, and I still remember that I had made this statement when I was invited at IMA Kalyan yearly conference, that hypertension is not a disease. Hypertension is a sign. Hypertension has to have some reason behind that. The way we call it as idiopathic hypertension, many of idiopathic hypertension are actually under investigated, and we don't find the reason for it, and we just keep on prescribing antihypertensives left, right, and center, and it is like giving paracetamol for controlling fever. Unless we find the cause of fever, we cannot treat it. So the only paracetamol is symptomatic treatment. So giving only calcium channel blocker or ACE inhibitors, we are blocking the body's reaction. That body is telling us that there's something wrong within me, and you need to find the cause for that. Without doing that, we just keep blocking the reaction of the body. It is necessary, like as I said, paracetamol is necessary for management of fever, but the management of fever does not end by only giving paracetamol. We try to look for cause of fever like malaria, typhoid, and whatever. So similarly, in hypertension, sleep apnea can be one of the important causes. Like other, as you know, that can be hypothyroidism, it can be rare kidney disease or whatever. But sleep apnea is one of the commonest causes here. And similarly, diabetes. And that also is obviously the reaction there. So both these diseases, whenever these patients come to us, we must ask them sleep history. If our hypertensive and diabetes walk out from our clinic without we asking sleep history, we have missed on something. We must ask them how they sleep, and then listen to their stories that they describe. Similarly, this PIH is pregnancy-related hypertension. Now that is also a very important thing that we have to remember, and the GDM, that is gestational diabetes mellitus. In pregnancy, sleep apnea worsens. So ladies who are having borderline sleep apneas when they get pregnant, because of various physiological changes that are happening within us, including water retention, including the weight gain that normally happens, the increase in the size of the abdomen because of the increasing size of the uterus, the diaphragm shifting upward, all these things will worsen the sleep apnea. And they are the one who will have worsening BPs, and they can really get into trouble. So we have to suspect. Unless we suspect and unless we look for it, we will miss sleep apnea. So please remember that. Coronary artery disease, heart failure, pulmonary hypertension, atrial fibrillation, and even some chronic edemas, which is because of fluid overload state, can be because of abnormal sleep, that is sleep deprivation caused by sleep apnea or any other cause. So here we have to keep in mind and ask our patients, and all these patients have to undergo the testing for sleep apnea. We keep doing lots of health checkups. Our patients also nowadays on their own do health checkup, but our health checkup packages are still not including sleep study as a part of that, which is going to be the need of the hour. And I think it will happen in near future that we will start doing sleep studies as a part of health checkup, especially whenever we find illnesses like this as a part of routine health checkup. As you see in this slide, 80% of drug-resistant hypertension had sleep apnea, or 58% of all diabetics, they tend to have sleep apnea. Congestive heart failure, 70%, atrial fibrillation, 50%. If you take all hypertensives, 45% can be because of sleep apnea. So all our hypertensives must undergo sleep study. This is a take home that I want to give you from this talk. Please do not miss on that. Unless we look for it, we will not find it. What are the other symptoms and diseases which they can come? Cerebrovascular accident. It can be stroke or bleed, and the chronic degenerative brain disorder, Parkinsonism, dementia, and other day-to-day problems like irritability, quarrels occurring because of that, poor interpersonal relationship, difficulty in concentration, learning difficulty in children, anxiety, depression, you name it, and it can happen because of sleep apnea. All these are there on internet. You just put this word and put OSA along with that, anxiety and OSA, dementia and OSA, and you will find there are lots of studies which are already there. Even in kidney diseases, you can see that one can get even CKD because of long-standing sleep apnea caused by focal segmental glomerulosclerosis. Nephrolithiasis, the kidney stones that we talk of, there is a strong link between sleep apnea and that. Prostatomegaly, sexual problem, erectile dysfunction to hypersexual behavior, loss of libido in girls as well as in infertile couples, especially the PCOS, and the infertility which is because of all these things. So in where I am attached at Vadia Hospital, I see a lot of infertile couples there. And infertile couples, when I look into all these histories, I find lots of sleep apnea in them. But the awareness amongst all the specialties has to increase so that every individual subspecialty themselves will ask for sleep study testing and find more and more cases and encourage them to get treated for that. Patients who are going to IVF centers, I would say that all of them, without they improving their weights and without they undergoing a proper sleep analysis, to further fertility workup that happens and further all the embryo transfers and occur, the success rates are not good because they themselves are not receptive to have those embryos and sustain further. So that is the problem. So we need to look into that. What are the other things? You will be surprised that even frozen shoulder can be because of sleep apnea, because the person tends to sleep more on the sides. Because of the sleeping on side, there is pressure on the shoulder. The shoulder gets more and more affected because of the hypoxia, because as the capsule of the shoulder is not having good blood supply. So these are the areas which are going to suffer more because of hypoxia, which is going to happen at night. And on top of that, the pressure that one puts because of the sideways sleeping. The people with sleep apnea do not find it easy to sleep in supine position. So they choose to sleep on the sides, or they sleep also in prone position. So prone sleeping is good actually for sleep apnea, but sideways sleeping can damage their shoulders. Similarly, there are accidents. Road traffic accidents can occur. Even the major accident like Chernobyl or even this Union Carbide accident which had occurred, it was found in investigation that it occurred mainly because of sleep apnea, because all these happened at the night time. Osteoporosis can occur because of sleep apnea. If you come to ophthalmic side, glaucoma can be because of sleep apnea, because it's again a neurodegeneration. Glaucoma is not only increased pressure of the eyes. Glaucoma is where actually the optic nerve is getting damaged. Age-related macular degeneration, hearing loss can occur because of sleep apnea. GERD, gastroesophageal reflux disease, irritable bowel syndrome, more seen with UARS, non-alcoholic steatohepatitis, and cirrhosis of liver, which is a very major problem. People who have not even touched a drop of alcohol, they tend to develop non-alcoholic steatohepatitis and finally end up with cirrhosis. So all these are important. So as you must have seen, orthopedicians, ophthalmologists, ENT, gastroenterology, or obstetrics and gynecology, neurology, cardiology, nephrology, all the branches, these symptoms are touching. And all these branches are seen by family physicians. So unless family physicians look for it, all these specialties look for it, we are going to miss lots of sleep apnea. Even sleep apnea can cause deficiency of so many vitamins, because there is continuous turnover happening because of excessive demand from the body, because there's too much of oxidative stress. So all these vitamins get overused. And as you would be surprised or not surprised, I would say by now, that infection proneness, people who are getting more infection also can happen because of sleep apnea, including COVID. There are studies that people who have got sleep apnea have suffered more from COVID. So this is interesting. Male pattern baldness, those especially who have a genetic tendency to bald, they are likely to worsen because of sleep apnea. And on the whole, it is the premature aging that can occur because of sleep apnea. So this particular overview, I'm sure must have will help you all to consider that we need to look for these cases of sleep apnea in such patients who are coming with these symptoms and diseases. Now, what is the importance of sleep? As we have talked initially, it is 1/3 of time that we spend in sleep. It allows our body cells to heal. It boosts immune system. It also rests our heart and the cardiovascular system. It enhances the memory. And the earliest symptom that we see because of sleep apnea is the damage to the brain. So our brain being the most sensitive, or the neural cells are the most sensitive thing, they will suffer the most, and that is how the whole work efficiency and everything of the other person's ability to perform goes down. What should be one's ideal sleep? The ideal sleep duration should be at least 7 to 9 hours. So please note this, and it should be in the biological clock pattern. So that is in the circadian rhythm. Now, as I told earlier, because of the availability of artificial light, we have been playing with our sleeps. And people who are working in shifts, especially those who are having jobs which are related to early awakening, there are vegetable vendors and those who are dealing with milk business, they have to get up even at 2 o'clock, 3 o'clock early in the morning. So all kinds of demand which has come up, and we want to satisfy everybody's demand, and in that process, we have forgotten what our bodies actually need. If you just ponder for a minute, we are all just in last maybe 400-500 years, we have come so fast ahead that what our ancestors were doing, we are not doing now. Just think of the caveman who was actually living in caves, who did not have artificial light. After the sun had set, with whatever little light that they were having from the torches and all, after they used to obviously sleep, they will not remain awake till 12 o'clock, 1 o'clock, watching matches or even watching screens and other things, and or some people even doing other activities at late night of entertainment, so-called entertainment activities. So all this was not happening. Early morning awakening, when the sunlight would just begin, was a routine thing. So this is the circadian rhythm in which our bodies have actually, our genes have been tuned to stay in, but we are going exactly against that, and we are paying the price for that. As I have written here, the maximum sleep is needed in children, and it reduces with age. But our children are now, in fact, falling prey to the screens. They are remaining awake till late nights, or they are, in fact, made to even study till late night because of the competition and the pressure on them. So the way in which we are expecting from our younger generation, it is creating tremendous problem. And I would like to share with you that the sleep apnea is not a problem of middle age or old age. Many of the sleep apneas have actually started in young age group only. So there is a significant sleep apnea which is there in the younger generation, which also our pediatricians and our even the dentists and the ENT surgeons need to pick up, or they are rather picking up and helping them. As I just now mentioned, there is a big role of dentists which is there in the management of sleep apnea or the diagnosis of sleep apnea, because the whole structure of our maxilla and our mandible is also deciding the airway. So there is a branch which is coming up called as Airway Orthodontic. So we tend to take our children to orthodontics to improve the alignment of the teeth. But it is not now focusing only on the alignment of the teeth. They also focus on improving the airway so that the breathing of the child improves. And if the child is not breathing properly, there is going to be deterioration in the scholastic performance, the behavior of the child, irritability, even this attention deficit problem, hyperactive children, or those who are repeatedly falling ill and sick. So many of them may actually have underlying sleep apnea. Even the tonsillar enlargement can cause sleep apnea. So such children, in fact, are helped better when they undergo adenoidectomy or tonsillectomy. So this is how a family physician who actually deals and treats persons of all the ages, right from children to old age, have to be aware that where all the sleep abnormality could be playing a role. As I have mentioned earlier, the sleep latency has to be about 15 minutes. Then we go through the non-REM and the REM sleep, where the REM sleep is seen mainly with sleeps. There are no awakenings from sleep normally. As I was saying, the people go for toilet and all completely awakened. That is not normal. But mild arousals keep happening in between when we are changing the sleep cycle, and should be no need to urinate. So these are the stages of sleep, as I have mentioned. We can go ahead from that. What happens in stage 1 is that body relaxes, and then brain slows down, and mainly stage 3, or now 3 and 4 stages have been combined. They're called as stage 3 only. That is mainly the restorative sleep. And people who are having light sleepers, or those who are suffering from sleep apnea, they do not enter into this stage 3 sleep at all, and they tend to keep fluctuating between stage 1 and stage 2 sleep only. And that's why the restoration which has to happen in stage 3 sleep does not happen, and they don't even go into REM sleep properly. So the dreaming is not there. So please ask your patient whether you get dreams. And the natural normal dreams are good, but if there are scary dreams, which are nightmare type of dream, that can also be a symptom of sleep apnea. So be aware about that as well. So what happens in the sleep architecture, the early stages, we can experience little of hallucinations also, sometimes a startle which can happen in that stage. And in N2, N3, and N1, N2, N3 sleeps, as I said, that we go through the lot of restorative processes. These are little more details, but I think we have discussed many of that. We need not dwell much. And the REM sleep, that is a time where the dreams take place, and it occurs every 90 minutes. And as the night progresses, the REM sleep duration increases, and these account for generally 20 to 25% of total sleep time. So nowadays, these smart watches which have come, which people also come to us with, they are of some use. They are not, don't sort of disregard them. It is based on a principle called as actigraphy. And in that principle, the way the person moves about in the bed, and that abnormal activity can tell us that how deep the person has had a sleep. So if the person is not going into deep sleep, definitely try to investigate the person further and do the sleep study for them. So as we said, usually the sleep pattern awake is 5%, and REM sleep is about 20-25%, and stage 1 and 2 about 50%. So these sleep cycles are about 110 minutes. So, and such 4 to 5 cycles will happen. So about I would say 1.5 hours or so is one sleep cycle, and in between the sleep cycle there is a mild arousal that happens. And that's why it is said that if one has to sleep even in the afternoon time, ideally one should sleep for about 1.5 hour period of time, so that it is a full sleep cycle that one goes through, or it is a very short nap. Anything in between that if we take, then that afternoon sleep also may not be that refreshing. So that's one take home point. There are various changes which are occurring in sleep, and which are good for the body. There is increased parasympathetic tone, decreased heart rate. This is that good sleep that happens, and there is decreased salivation. So all this, when it is not happening, as we have said earlier, there is worsening of all these symptoms. Especially if you see the last point, that is the renal point, there is in fact decreased urine production that occurs at night, and that's why there is no passage of urine that happens at night. But in sleep apnea, exactly the reverse happens. So for having a good sleep, one has to follow sleep hygiene. Now we have been all talking about using soaps and using sanitizers to maintain hygiene of our hand in COVID time. We have discussed that a lot. So similarly, there is a hygiene for sleep also which we are ignoring. So how to do that? One has to maintain a good regular bedtime and awakening time. So don't keep on changing your time. So those who are In shift work, this is already going for a toss. Keep the bedroom dark and quiet at a comfortable temperature. Do not nap during the day as far as possible. Strictly avoid alcoholic beverages because alcohol worsens sleep apnea. So those who are already sleep apneic should never do that. Avoid caffeinated beverages after noon time because then also it is a stimulant. So even excessive stimulant is not good, and excessive sedative type of substance like alcohol is not good. Smoking obviously not good because again it's a stimulant. Do exercising just before bedtime is not good within 3 hours. You do not use the bedroom for watching TV or reading or solving any complex brain activity function. Use only for sleep and sexual activity the bedroom. Avoid mental stimulation like heated arguments or financial calculation 1 or 2 hours prior to sleep. So these are important factors that one has to remember, and these are the factors which lead to poor sleep. Alcohol, some drugs, the jet lag, as you know, shift work, bedroom temperature, and the technology, the technology causing the net addiction. So net addiction is a big problem, and the caffeinated drinks and all that. So these things should be definitely avoided. Now, as we see, the OSA is a major disease. Now we have realized that. But what is the global burden? How severe and how significant these diseases can be understood when we look at these trials? And this is a 2019 paper that we are talking about, where the estimation of global prevalence and burden of obstructive sleep apnea has been done, and the literature-based analysis came in Lancet. It's a very major journal that it came in, and where it was shown that globally we have about 1 billion sleep apneics and about 29 million Indians are also estimated to be sleep apneic. So this is a huge number that we cannot ignore, and more cases as we investigate, we will definitely get more and more abnormal cases and we'll be able to help them. So this is the responsibility on us as physicians, family physicians, and all the subspecialties, that we need to diagnose the cases and help them. There is a huge economic burden also that occurs because of that, and it has been shown that when we compare the patient of without OSA and with OSA, there is twice the healthcare cost that happens in persons who are suffering from OSA, 50% more physician visits, and there are longer hospital stays. So there is a big economic consequence of sleep apnea also. Now, how to diagnose OSA? Let's come to that. We need to have high index of suspicion. Without suspicion, without being a paranoid person, as doctor, we cannot diagnose the cases. So we have to suspect, especially those cases where all that we discussed earlier, those various symptoms and diseases. If we are finding any of those in our cases, please keep our eyes open and don't think that the ultimate treatment of sleep apnea is going to be a Cpap machine. The machine treatment, my patient is not going to anywhere accept, so why should I do the test at all? That kind of approach also I have seen in some of doctors, that they think that anyway there is no easy medical treatment available for this illness, and that machine is a very complex thing. Though the patient मेरा लेगा नहीं तो मैं test ही क्यों करूं? And similarly, some of the smart patients also think in this manner. So we need to counsel them properly. And for diagnosis, obviously, we need to take a good sleep history. So to younger doctors, younger physicians, or even some students, if they have logged on this webinar, my sincere request to them is to include one question in your history taking, is that आपको नींद कैसी आती है? आपकी नींद कैसी है? आप कैसे सोते हैं? This question should be included in most of our patients. How we ask, like, what is your name and where you stay and what is your occupation? Similarly, sleep should be included, sleep history should be included in our regular questioning. And even in the medical curriculum, I would urge that if there are some policy makers who are listening to this and who can influence the doctors who make the medical curricula, that this disease of sleep and sleep apnea should be included as a prominent topic and should be taught to our medical students seriously, and they should also, then only they will start looking for these cases, because without that we are going to miss on many cases of sleep apnea. What are the risk factors for OSA? And these are the situations when we look for OSA more aggressively. obesity, but don't go by the fact that a person is non-obese, he or she will not be sleep apneic. So keep your antennas still open. Males are more likely to get OSA, postmenopausal women, increasing age as the one ages, sleep apnea worsens during pregnancy. I will again stress the fact and urge to my gynecology and obstetric friends that please do not disregard sleep apnea. It's a very important disease in pregnancy also. Those who are alcoholic and those who are using sedatives, especially the benzodiazepine group of sedative, those who are using, their sleep apnea tends to worsen. So it's a paradoxical thing that keeps happening. नींद नहीं आती है इसलिए we take more of benzodiazepine and it worsens sleep apnea. So especially those phenotypical sleep apneas who tend to have insomnia as presentation, they in fact are prescribed sedatives and it paradoxically can worsen sleep apnea. So we have to be alert. Smoking, diabetes, people with family history. Now this family history is a very, very important point. I would tell that if somebody from the family has got sleep apnea, please caution them before that person leaves from your office that please, that whether your brother sister also has a similar complaint, whether your parents have a similar complaint or their children have a similar complaint, please inquire, because that is how you can pick up cases in this manner and you can help them before the damage is done. Once the damage is done, it may be a bit too late to reverse. Person at the age of 40 suddenly dies, drops dead, no vices, no smoking, no alcohol, was regularly doing exercise. Only bad thing that with that person was that the duration of sleep was only 5 hours or rather 4.5 hours. Because exercise करने के लिए जल्दी उठना है, मुझे जाके जिम में जाना है, रात में देर रात तक प्रैक्टिस करनी है, medical practice. Even among our doctor community also this happens, that we compromise on sleep so much that we end up sleeping for too less hours. In fact, today's seminar also I wish that it was during the day hour on a Sunday, but somehow Sunday IMA all functions are busy, so we are having the seminar also at night time. So that is again a big paradox, but we have, for sake of sleep apnea, we can do this, but we should sleep on time. My request and I urge that we all should try to focus and rather at least aim to sleep before 10 o'clock. If we can do that to ourselves, then only we can do to our patients. If it is not 10 o'clock, then at least 11 o'clock. But crossing 11 o'clock limit is actually we are doing injustice to ourselves. People with anatomical abnormalities like small facial bones, narrow nasal passages, people with DNS and all those kind of things are also more prone for sleep apnea. And those are having small jaws, retrognathia, the small jaws. So when, as a dentist, if I have to tell you, it is called as type 2 closure, right? Like when they close the teeth, I mean, if you ask the person to bite, it's a deep bite. It's called a deep bite, if I have to use the correct word. The upper teeth will overlap the lower teeth. Now that is called as deep bite. So people with deep bite have smaller lower jaws and they are the one who are likely to have sleep apnea. And excessive soft tissue in the upper airway, which can be judged by, there's one more slide which I'll take for, that's called Mallampati score. So if you're suspecting sleep apnea, ask the patient to just open the mouth without protruding the tongue. Ask the person to just open the mouth and look for these structures. If we are not able to see the uvula, if you are not able to see the pharynx, it is falling in the category where they may be sleep apnea. So from class 1 to class 4, the probability of having sleep apnea increases. So look for the throat and you may be able to catch sleep apnea. And this is one questionnaire which also helps us to diagnose sleep apnea, and that is called stop bang questionnaire. So it's where it asks the question whether you snore loudly and louder than it is talking or loud enough to be heard in the with closed door, yes or no. Do you feel tired and fatigued during the daytime, yes or no. Has anybody stopped you breathing during sleep, that I was mentioning about that partner observed apnea, yes or no. Do you have blood pressure, are you being treated for that, yes or no. And in bang, it is if your BMI is more than 35, age more than 50, neck circumference more than 40, that your shirt size, and if you're male or no. So with these, your chances of having sleep apnea, if it is more of yes, then your chances of having sleep apnea increase. So this questionnaire also helps you. But once you have developed the gut feeling for sleep apnea, let me tell you, you don't need to ask this question. You yourself start picking cases. That's why I did a sort of analysis of cases which I have referred for sleep study, and I found that almost 80 to 90% of those who have referred for sleep studies have turned out to be positive. So your success rate of catching sleep apnea increases day by day as you start suspecting sleep apnea. Now, there are ways in which you diagnose sleep apnea. This is called as sleep study. Now, this sleep study can be of different types, type 1, type 2, type 3. We'll just go over that briefly because I will complete this and then I'll tell you what is in our mind. That there are full polysomnography study and ambulatory. Now, the polysomnography full study is done in the hospital. So where you need to get admitted and where there is a detailed wiring that happens like this. So it's something called a sleep lab, where a person will be monitoring your sleep throughout the night, and there are many wires will be there, and you'll be sleeping actually in the hospital. Now, this is the most ideal way of diagnosing sleep apnea, but that does not mean that it is a must to do that. You can always diagnose sleep with a lesser complicated machine, that is type 2 device, which is like a polysomnography which is done at home, which can be observed or non-observed, where a person from the lab can stay in your house and can actually do this. But the best thing that I have found and I have used for most of my patients is type 3 device. That is a ResMed's apnea link device, and it has got 4 channels, and it includes a pressure transducer, the snoring, which is the respiratory effort analyzer, and a probe for your SpO2. So this is what is the most commonly used machine, and it looks like this. This is the apnea link machine, which has this 4 channel, as I told you. So in which there will be a small cannula in the nose of the person, and I think a picture of that. Yeah. So this is a cannula which is put in the nose, and this is the band which is around the chest is actually looking at the respiratory effort, and in the center this the small box which is there, to which the channels are fed, and this data is stored in that, and there's the analysis that happens on the finger. You'll see that this there is oxygen probe. So this is the test which I will strongly recommend that we should keep doing. When you are suspecting this, do this test, and I urge that try to keep the price of this test as minimum as possible, so that more patients will readily do the test, and that is obviously in the hands of the companies like ResMed and their associates which are there, and we doctors have to keep the minimum reporting charges for that. I generally sort of waive off the reporting charges completely, and I just get the study done, so that the burden is not on the patient, and I will just see the report as a part of routine, and will diagnose the case, because that's how more patients will do it sort of readily. So this is that, because there's what I said, this the complex sleep studies. Now people sometimes are not very happy doing, because they get anxious because they have to stay away from home. Then there is a they find that somebody watching you is also something you're not happy about. So in this test, you are at home only, and you are on your familiar atmosphere, and you are still, this machine people get, so they actually fear कि ये इतना नाक में लगा के भी हमें नींद कैसी आएगी. That's a common question that you face, which you need to allay their anxiety. That's a very soft probe. कुछ नहीं होगा, वो जो उंगली पे हुआ लगाया हुआ अभी भी वो सॉफ्ट रबर का ही होता है, उससे भी आपको कुछ दर्द नहीं होगा. चेस्ट का भी है, वो नेचुरल है. आपको most important advice that you should tell them is that don't consider that you have to remain in only supine position. You can turn on sides, because some people feel that test हो रहा है मतलब they will just like stiffness, they will lie in one position only, and that can create problem. So we have to counsel when the test is ordered. We have to give them an idea what they are going to face, because the people from the sleep lab will go to their residents and give this machine and help them to put it on. But if we have already preempted them, we have already made up their mind, they are ready to accept it easily, and then the probability of they going through the test is also good. Because if they don't sleep on that night, then we are going to also miss sleep apnea. So the person has to go into deeper sleep. Even when they come to us with the sleep report, which is an abnormal sleep report, many of them try to say कि मुझे तो ठीक से नींद ही नहीं आई थी इसलिए मेरा रिपोर्ट खराब आया. Because people feel that अच्छी नींद आती है कि बुरी नींद आती है वो देखने का ये रिपोर्ट है. But actually those who have not gone into deep sleep, their report can be in fact fallaciously normal looking. Because the worst report comes when they go into deep sleep, when the muscles relax more. So that is, we have to something which you have to explain to them and tell them that if you sleep well, your report will be something which I want to see, what is actually happening every night. It is not that ये आपकी कोई एग्जाम होने वाली है और एग्जाम के दिन आपको जब एंजाइटी से पूरी रात भर जगना है, ऐसे नहीं है. So you have to take this test in a very natural way. So all this kind of counseling in advance help them to go through the test better. These are the various terms that are used in sleep disorder breathing. There is flow limitation, as I told you. There is something called a hypopnea. As I told you, apnea, hypopnea index, which is there. So in hypopnea, you'll find that there is more than 30% or equal to the 30% reduction in airflow, which is lasting to for more than 10 seconds, at least 3% oxygen desaturation from baseline. So this is something which is called as hypopnea. These are all definition with the machine is going to follow. This is something which you don't have to do anything about and don't need to remember also. It's for and if the airflow cessation is happening for more than 10 seconds, then it is called apnea. So with what the machine does is it counts all the apneas and hypopneas throughout the night, and then the number of apneas and hypopneas are put together, and the number of hours of sleep will be the denominator, and then you get the apnea hypopnea index. So there are various types of apneas that you see in that: obstructive apneas, central apneas, and mixed apneas. So in obstructive apnea, what you see is that patient is actually trying to breathe, but there is no airflow happening. That is obstructive. And in central apnea, the person also is not making any effort, and there is no airflow, obviously. So that is where the brain has forgotten to breathe. In obstructive apnea, brain is actually pushing you to breathe, but there is obstruction in the airflow. And in mixed apneas, patient initially does not make effort, but then later on the effort resumes. So there can be mixed apnea. So this is more theoretical part. When I and Dr. Sangle, we discussed, we decided that today's seminar or webinar, let it be more of an introductory seminar about this. Next Saturday, he wishes to have one more of that, where we can go into details of all these finer things and the treatment part of also. So if you all have enjoyed today's seminar, we can go ahead with the treatment seminar next time more in detail. So I think we are almost covered 1 hour of my talk. Let me, if we have some few hours, I can just go through the last few slides which are there, which you need not focus much on. This is one sleep test. That is a very compact sleep study test which has come from ResMed, and it can become the trend for the future. But right now, it's not being followed. And the management part, as I told you, I can just show you the machine and how it looks and what we do. But the details of management can be a full 1 hour webinar next time. So I'll just go through that. Important part is the lifestyle changes. Weight reduction plays most important role. So we have to focus on weight reduction, but weight reduction has to go hand in hand with the treatment of sleep apnea. So if both go together, the person cooperates better, the hunger comes under control better, the dietary advice that we prescribe works better. I generally recommend 2 meal pattern, and that in my experience has helped my patients the best. Sleep hygiene also has to be explained to them. It's something called as myofunctional exercises, which tone up your throat muscles, your tongue muscles and everything, and that also improves the sleep quality. Yoga and pranayam has immense benefit on controlling sleep apnea. So our patients should be motivated to do this, and regular physical activity. This lifestyle changes cannot replace the PAP machine, or other PAP machine cannot replace lifestyle management. So everything has to go hand in hand. If everything goes together, the results are the best. Drug treatment, unfortunately, there is no good drug that will cure sleep apnea. So it's not that easy that we just prescribe a drug and the patient walks out and gets well. It does not happen so. Surgical treatment, is not that easy and not everybody benefits. So there are very specific issues if you have picked up, like in children, if we do the adenoid and tonsillectomy, they benefit, but otherwise it's not an easy thing to do. Whereas dentist's role in management of sleep apnea is important, where we use mandibular advancement device and where we keep the upper jaw in a forward pulled position. This is how the mandibular advancement device will look. It sits on the mandible and it keeps the upper jaw pulled forward so that the tongue does not fall. And the most important is the continuous positive airway pressure, which was invented early by Professor C. Sullivan, and now it has come to a reality. What it does is that it blows air into your nose or nose plus mouth at a higher pressure. So it acts like an air splint and does not allow the collapsing of the airway. And it is the most effective non-invasive therapy of sleep apnea. The PAP therapy keeps the airway open like this, how it looks in this picture. This is how the machines look. This is the latest machine of ResMed, that is AirSense 10. It's an auto Cpap machine. Auto Cpap machine has the advantage of adjusting pressure. So we can give either a fixed Cpap, which is the fixed pressure, and it is identified by doing something called a Cpap titration. So by doing the titration, we know at what level the pressure should be kept. But this is the pressure which does not fluctuate. So patient may be uncomfortable. So those who require a lesser pressure, we can give fixed Cpap. This is how we identify the pressure. We can do this next time. There is something called bi-level pressure that is called BiPAP. This also is also used where the patient has COPD or overlap syndromes or those having central apneas. And one which is the best treatment for sleep apnea is the automatic positive airway, the APAP machine that is called as, in which there's a dynamic variation of pressure as per the patient's need. And that's how the patient, there's a servo mechanism. The obstruction is sensed by the machine and the pressure is adjusted accordingly. So there's pressure identification. It also helps for positional and REM related voices. Like if during the REM sleep, if the apneas are going to worsen because of the further collapse of airway, that time the machine will sense that and give the pressure. Now, if you see the mask also, this particular patient has a different mask. If you see that this lady who is wearing the mask, that is the it's a mask. It is a mask which is not covering the full face. It's called as a nasal pillow mask. It is something. So all that we will discuss in the next webinar. But I'm just giving you an idea. People who are going through bariatric surgeries and all, they also, or rather, the obese patient, they suffer better. They perform better with APAP machines. People who tend to drink also perform better with APAP machine, because they are on that night when they have consumed alcohol, the requirement of pressure will go up. So they will not be good with fixed CPAP. So there you need to have a variable pressure. There is a lot of troubleshooting which we need to do for the patient. So this is where the skilled job of a doctors who are specialized in sleep medicine comes in, how to help the patient. But our most of us family physicians and consulting physicians also can get trained into this and help our patients by adjusting the finer details. And to improve the compliance, what is most important is patient education, optimization of the positive airway pressure, the choice of mask, that is the interface that we call it as, is very important, humidification, and there's something called a Tele Monitoring which has come now, which is possible with this new machine, that is AirSense 10 machine, where you can actually see how our patient is doing sitting in our clinic. It is through the cloud technology that we can actually see what our patients are doing, and we can guide them. We can even adjust their settings with the help of that. So that is the next level of management of OSA. But I think before we reach that, our role is to first suspect, motivate our patients, tell them, and more consultants or other family physicians, when they start telling, say if I have told my patient that you need sleep study to be done, that patient is obviously going to go back to the family physician and check that consultant ne bola. Now, if the family physician does not give enough importance to that test, the patient will not do it. So it has to come from all doctors as a team. Then only our patients will follow the advice, and they will benefit the most. And I feel the world will become a better place to live in when people will start sleeping better. The quarrels which are happening, the wars which are happening, all the rat race that is going on in this world, I think is primarily because we are not sleeping well. If we start sleeping well, we will definitely enjoy our lives much better. We may have less luxuries, we may have less food to eat, but we will definitely be happier persons. So on this note, let me thank you all, and I am open to questions. But I really thank from bottom of my heart again to Sangle sir, and thinking about this webinar itself is a huge thing. I think he has done a great social service, and I'm not saying that I'm an ultimate authority on sleep medicine or anything, but I'm a simple MD medicine physician who has developed interest in sleep medicine out of experience, and I'm sharing my views with all of you. What I've done today is that I have shared my way of looking at sleep apnea with all of you. It's a raw field. Let me tell my students also who are attending that please take up this speed with interest, and you can learn more, do studies, or take this as a specialty branch, learn more about sleep medicine, spread the awareness. I was expecting some of my daughter's friends also to join this webinar who are engineers. My daughter is in IIT. So I had told her to help make some of them also attend it, because we need to manufacture the machines at economical price. Right now, the machines, when the price is told, sometimes the patients are not happy paying 40,000, 50,000 from the pocket for buying the machine. So as Indian population needs it at such a large level, we need to have companies manufacturing the PAP machines also. China is manufacturing PAP machines, but the quality wise, there is always sometime a doubt. So we need to have good quality PAP machines coming in India, which will be more compact. The interface will be good. So there good research has to go on this topic so that it will become easier to follow. So thank you all. I really thank the organizers, and I'm open to questions.
Thank
Yeah,
you, sir.
thank you.
Thank you very much. Thank you very much, sir, for such an informative and excellent talk, and that too in a very lucid manner. Thanks a million to you. Now for question and answer session, I would like to hand it over to Dr. Himanshu Thakkar and Dr. Rajan Man. Himanshu and
Yeah.
Rajan Man.
Yeah, good evening, sir. Thank you, Dr. Sangle, very much. I think we had a very informative lecture, and Dr. Shikarkhane has certainly aroused a lot of interest. He has generated a lot of interest in this topic. And for me, I think I got to know a number of different facts today. Just like animals are less prone to sleep apnea, and because of the evolution of larynx and pharynx, we human race are directly proportional to the sleep apnea because of the evolution. Of course, like relation of frozen shoulder to sleep apnea, the undercurrent of infertility to sleep apnea, the cascade of sleep apnea leading to diabetes and blood pressure. All these things are, I think, new information to us. And certainly we will be looking forward to your next session also for the treatment. But apart from that, now I would like to invite our audience to get along with certain questions. I think definitely people must be having some queries, and Dr. Shikarkhane sir is always there to answer them. So kindly come forward with your questions, and we'll have we had a very interactive session. We will have a very interactive session. Yes, please do ask your questions.
Sir, Ajit this side. Actually, already there are 3 questions in the chat box. Dr. Amod Borukar sir has 2 questions, and there is one more question from Dr. Gurudatta Gaitonde. So it's in the chat box.
I'm not able to see the chat box. If you can read out for me, I'll be happy.
Sure, sir. So the first question from Dr. Amod Borkar sir is, does prone breathing help? Reflux acid disease induces sleep apnea? Do sedatives, tranquilizers, and hypnotics worsen it? So do you want me to repost it again in the chat box?
No, I am now seeing the chat box. Can you just come back? I can.
So
I am seeing that question now. Yeah.
Okay.
Yeah. So what he has asked is, does prone, yeah. So prone breathing does help. Prone breathing, in fact, has been the one of the greatest therapies as far as COVID management was concerned. So now we have understood the importance of prone breathing. So in prone breathing, the simple thing that happens to sleep apnea is that the jaw falls forward because of the prone position, and in supine position, exactly reverse is happening. The jaw is falling backward. Now tongue is attached to the jaw. And when you are in supine position, the tongue falls into the throat and further compromising the air passage. So if you are in prone position, as the jaw is falling forward, the sleep apnea reduces. So that is the answer to that. Now, reflux acid disease does not induce sleep apnea. In fact, sleep apnea causes reflux. So that the stress of the reflux, see, when we are in threat, any threat, you tend to have vomiting and the body wants to empty out the GI system. As you know, that people in anxiety state also, they tend to vomit, they tend to even pass stools also. So IBS has a link with that. Similarly, GERD has a link with that. So under stressful situation, all these things starts happening. So there is a tendency for the reflux as the sphincter at the lower end of esophagus tends to relax. So is the other way around. Sleep apnea causes GERD. And sedatives and tranquilizers, hypnotic, they do worsen sleep apnea, because again that is causing relaxation of the brain, and the brain which is trying to awaken you from that hypoxic state is not allowed to do so. So one may not wake up from the sleep that frequently, but at the same time, more severe hypoxias will occur. Say, for example, if the saturation has dropped below 90, it has gone to 88 or 87. At that point, the brain senses it and awakens you. Here, if the brain is not allowed to do that, the saturation may drop to even 70 or 60, and still the brain will not awaken. And that is why there are sometimes deaths occurring in sleep also because of sleep apnea, where the patients have worse. And as I told you, there are different phenotypes in sleep apnea. So there are some phenotypes where the brain is less sensitive to the hypoxia. These are the people will go into deeper hypoxias, and they tend to have more problem with coronary artery disease and cardiac problems. Whereas people who are excessively sensitive for drop in saturation, they tend to become more anxious, more with their symptomatology is a bit different than this. So all that we will discuss in next session. We can go into these details next Saturday. Yeah. So next question is
just to add on. Good evening, sir. This is Dr. Imanshu. I'm pulmonologist here in Kalyan.
yes.
As there was some one comment regarding the prone positioning. Usually, those who are obese, they can't. They are uncomfortable in the prone position also. So usually they prefer any of the lateral position. So yes, prone position too helps, but again, because of the obesity and everything, they are not comfortable lying down in prone so easily.
So lateral positions is what also is significant. In fact, the treatment in earlier time was to just tie a ball on the back side. Or in fact, now also there is a device which comes, which you can put on the neck, and if you just become prone, then it just sort of awakens you, and or even rather the bed partner also kind of nudges the person who is sleeping in the supine position, and makes the person on the turn on the sides, and the snoring reduces. So exactly, I thank Dr. Imanshu that you brought out this point, that lateral position also significantly reduces sleep apnea, and prone may not be always possible, especially in obese persons. So, right.
Can I raise a question, sir? Dr. Ramchandani calling.
Yes.
What about the COVID? Did it have any effect on this sleep apnea, or there any adverse effects for the thing?
Sleep apneics had more severe COVID. In fact, they suffered from a more severe COVID. That has been proven in scientific observations, and it is there in the literature. So people obviously sleep apnea causes the cytokine storm and other that pro-inflammatory state which is there in the body is seen with sleep apnea. They tend to have high CRPs as baseline also. So on top of that, when there is an attack of COVID virus, it can be worse. And as we have all observed in last 2 years, it is the body's reaction to the COVID virus which has made you more sick than the virus itself. So there are some people who actually remain completely asymptomatic. They probably had a good relationship with that virus, and that virus just came and went away. And there are some who reacted more severely to the virus and developed the cytokine storm and the high CRP and everything as a marker of that. And they damaged their own lungs because of the fluoride reaction given by the body. So there is a lot which is beyond the common observation that we are doing. And these are the people who are suffering more. I think, Dr. Himanshu, if you want to comment on this, I would allow to listen to you.
Definitely, sir. Again, as I said, these people become hypoxic, especially during the night hours. And COVID, again, aggravating the hypoxia, especially the lung lesions. As we've already observed the happy hypoxia part in COVID. And again, the happy hypoxia part and the hypoxia with the cause due to the obesity, sleep associated disorder. So again, it is an aggravating factor, and yes, definitely the mortality was quite high in obese people also.
Yeah,
That was again definitely seen quite a lot.
correct. There's one question by Amod Burkar. Will curved airway in situ at bedtime to prevent instead of Cpap? Okay. Now he has thought of a way of treating this, that putting an airway inside to falling. But then keeping such airway, we do it for our admitted patients who are unconscious. But for a conscious patient to maintain that airway inside the throat is not an experience that anybody would like to have. Even these mandibular advancement device, which is sitting in the mouth, also is not accepted by all the patients. So your idea is obviously good, but it is not easy to accept by the human being. That's why this external air pressure causing the air splinting mechanism by which we keep the air passage open. By using I think I have answered that question. Anything else?
There's one more question by Dr. Jitendra Karnik. Is the treatment is for lifetime, or patient can be discontinued after improvement in the sleep pattern?
Yeah, it's a very good question. Dr. Jitendra is a good friend of mine. Thank you, Dr. Jitendra, for asking this important question. See, if it is a mild sleep apnea and the person really changes lifestyle, significantly reduces weight, and also starts doing regular exercises, myofunctional exercises with yoga, pranayam, everything, I'm sure it will. One may not need CPAP machine in the long run. Is possible, theoretically possible, but one has to do it meticulously. Even I have been recommending this saline cleaning that is in yoga. It is called a Jalaneti and all that, which is also useful for keeping your nasal passages open. So all these, in the ancient wisdom, if we use it to the best and the fullest, and if we make our sleeping timings correct, and follow everything, then maybe the PAP machine can be done away with. But by and large, at an initial starting point, if it is necessary, one should take the help. It is like somebody getting a fractured leg. And if you tell the fractured leg person that you are going to do only physiotherapy and your leg is going to improve, it may not sound good, though in the long run that may work. But then we need to put some plaster also for some time, and then gradually we knock that person from the plaster. So this PAP machine will act like a plaster initially for a few months to few years, and then if you can really change everything, then maybe one can sort of do away with that. But those with severe sleep apneas and those who are having real structural problem in the, it is good to continue using. So I generally explain to my patient that it is like wearing a spectacle. Now this spectacle is also a machine which we have accepted so many years ago, and now because it is accepted, we don't object to it, because so many of our colleagues are already using it. तो उसमें क्या है, वो भी चश्मा लगाए तो मैं भी लगाता हूँ चश्मा. But अभी CPAP का क्या, it is a new thing, so people have yet not started accepting. I actually had gone to Rajasthan about 2 weeks ago, and I traveled by the Rajdhani Express while coming back from there. And I saw that one of my fellow passenger used CPAP in the train at night. And it was such a nice thing to observe that the awareness has reached to a level that he has carried the machine and he has used it in the night in the train also. So that kind of compliance, if it can reach to, then our patients are definitely going to benefit, because compliance is very important. The more more number of nights one uses, and even during the daytime also, we have to tell them that if you sleep during the daytime also, please use the machine. And nighttime, obviously, one has to use. And the longer sleeping hours also important. It is not only the use of machine, the duration of sleep is also important. So covering that necessary sleep of at least 7 to 8 hours, that plus the good quality of sleep will really give you the most refreshing sleep. And once that happens, the day is yours. Then you can do whatever you want during the day.
Sir, I have got a
Any
query.
other questions?
Sir, I have got one query, but it is not for OSA. Those who are having shift duties like staff nurses or employees in the companies, shift duties, first, second, third, one week, rotational duties, or those who are having continuous night duties. Any advice for them?
It's actually very unfortunate that we are living in this kind of world that where we have to work at night. So there are weird things happen at night. I have seen people. There are areas where the municipal corporation water supply comes at 2 o'clock in the night or some 3 o'clock at night. So रात में पानी भरने के लिए लोगों को उठना पड़ता है. Then this mosquito menace is one thing which goes on for many months of the year when people's sleep is getting disturbed by the mosquito bites also. And on top of that, this shift duty thing, that and the way in which the shift duty is also rotated, it is so horrible that in 1 week only that you have to go through some 3 दिन के बाद duty change होता है. I mean, it is beyond our comprehension, and sort of nobody consults doctors for that also. I feel that is what things are happening around us. Only advice to them is that whenever they get a chance, they should sleep. I mean, that is good thing. And if the sleep is a difficulty to reset their sleep cycle, they can use sort of melatonin as a supplement, because that is something which can at least sort of fool your brain and can reset the circadian problem which is happening. So people in this jet lag and the shift duties can use melatonin, which is a safe hormone to take, and sleep well if you are not able to sleep at your will at when you want.
Thank you, sir. Dr. Rajan.
Yeah, hello. I think we are done with most of the questions.
Yeah.
And I think we will be eagerly awaiting you for the next session in which we can discuss the management of this ailment.
Sure.
So, has anybody got any other questions?
On CPAP, oxygen supplementation also required if SpO2 is low. There is one question from Amod Borkar.
Yeah,
Yeah,
please
so
go ahead, sir.
oxygen supplementation may be required, but only if it is the baseline oxygen is low, then one may have to use it. If there are hypoxias occurring at night because of the obstruction, then once you start using CPAP, automatically those hypoxias are significantly eliminated. So then one need not do that. But otherwise, if there's this overlap syndrome that we talk of, this COPD with this sleep apnea, there one may have to use oxygen also. Or those who are having underlying pulmonary fibrosis and all, there one may have to use oxygen.
Yeah, Dr. Surekha Itkar madam has requested, sir, that next session, if you can elaborate on melatonin, role of melatonin, it will be very helpful.
Sure, I will do that. Yeah.
Any other questions on our delegates? I think, thank you very much.
I think we should all sleep now.
Yes.
That is the message.
That is the message.
So anyway, I'll take the opportunity to present my vote of thanks.
Session.
Yeah. So initially, of course, Dr. Pushkar Shikarkhane, thank you very much for that very absorptive and very informative session.
Thank you.
And we are awaiting your next session as well. And Dr. Sange and other officials will do the needful to arrange the same. Dr. Rutika Bhosle also did a very nice job in introducing your profile.
Yeah,
And of
yeah.
course, apart from that, all other dignitaries, including Dr. Suhas Pinge sir, our President, IMA Maharashtra State, Dr. Mangesh Pate sir, and Dr. Who is the Secretary, IMA MS, and Dr. Rajiv Agrawal, who is the Treasurer of IMA MS. We thank them. Apart from that, Dr. Ramkrishna Londe, our immediate past President, IMA MS, and Dr. Ravindra Kute, President-elect, IMA MS, and Dr. Bandarkar, past Secretary. We thank them as well. All other officials from IMA MS as well. And of course, the IMA CGP Maharashtra State team, spearheaded by Dr. P.S. Sangay sir, who was instrumental in arranging this talk. We thank, and who also happens to be the Director of Studies of IMA CGP Subfaculty Maharashtra State. Dr. Rajan Sancheti sir, who is the Secretary, IMS CGP Subfaculty. Dr. Ramchandani sir and Dr. Huchandani madam, who happen to be the Joint Secretaries of IMA CGP Subfaculty, IMA Maharashtra State. We thank all these officials. And apart from that, our very own IMA Kalyan team, headed by Dr. Prashant Patil sir, who happens to be the President of IMA Kalyan, and Dr. Surekha Itkar madam, who is the Secretary of IMA Kalyan. Dr. Pansare madam, who is the President, Vice President, and Dr. Himanshu Thakkar, our very energetic person from IMA Kalyan, who also happens to be the Treasurer. And of course, at the end, ResMed officials, Dr. Vikas Singh and Ajit Matkar, we thank them for arranging this session in a very flawless manner, arranging this Zoom platform. We thank them profusely. And we thank all the delegates for being part of this today's session. We had a very good presence, upwards of 70, I suppose, and we expect more people to join us in our next session. Dr. Shikarkhane sir, especially you were very articulate in explaining all the facts about sleep apnea. And I am a family physician, and I have heard about sleep apnea, but a lot of things I have got to learn today, and it has aroused my interest. And as you said, one question I'll be definitely asking my patients: how about your sleep? Are you sleeping peacefully? And we'll try to elicit those symptoms and try to take the subclinical cases. We'll try to bring to the fore subclinical cases. That will serve the purpose of today's lecture, I suppose.
Yes,
Thank you
sir,
very
yes.
much, sir.
Thank you, everybody. Thank you, sir. We have learned new terms, that is sleep hygiene, and a lot
Yes,
of take-home messages. And before concluding, I announce that we'll be having next session, second session, on next Saturday, same timing. Thank you, everybody. Thank
All
you,
the
sir.
best.
Thank you, Himanshu.
Thank you, sir.
Thank you, sir. It was very nice.
Thank you, sir.
Thank you very
sir.
much.
Thank you so much.
Dr. Suresh, Dr. Manoj Verma, Jagdish sir.
I thank everybody. I hope I have not
Rajan
missed out
Sancheti.
on anybody.
I remember sir had come, I think, 2018 conference.
Yes,
17
yes.
or 8. Yes.
Sir was Sir and Dr. Nikhil Burkule. And Dr.
Burkule,
Pushkar
yes, yes.
Yeah,
Shikarkhane,
yeah, yeah.
They were having panel discussion on hypertension.
Hypertension, yes.
Yeah. Yes.
And sir has rightly mentioned, whenever there is hypertension, there is some cause,
Yes.
which
Yes,
we
yes.
tend to forget and write the pills. Very important. Take home message. Thank you, sir. So nice.
Thank you very much. Thank you.
Thank you, sir.